Thank you. This is a great segue to re-engage Senator Taylor in this conversation. And I'd just like to begin by some of the facts that you've produced. Senator Taylor, does that sound about right? The $19 billion spend and the 80% administrative opt-out, followed by a 20% goal,
Sure.
all of which amounts to about $130 million a year being spent in minority businesses of a $19 billion total spend by the state. Did we get that right?
Yeah, I think you did. And I thank you, Marlo. That was very enlightening. I wrote down as fast as I could some of the numbers you were talking about. But, you know, in reality, we don't have a managed care program with Medicaid. We have a managed payment system, right? I mean, care is not really a part of the equation. And this is goes back to an age-old discussion. One that really frustrates me, and that is, when are we going to ever focus on healthcare and do the things that you've talked about with SIMPCO? We keep focusing on sick care, and folks that are in the system, and like you say, they come in, see the emergency room as the point of contact for a lot of people in our communities, because we just don't have the system well enough established that we can really deliver healthcare. I am not a fan of the managed care system. I think that we have privatized most all of Medicaid at this stage, and I think that it has served the managed care companies well, but I don't think it has served the people well. And I think that's what we have to get back to. So I think you're right on target, and I think we have to get serious about fixing this problem.
The second thing, before I move off of this part of the financial part of the conversation, is that, you know, even without addressing, because time just won't allow us to get deep into the woods on this, but the premise that 80% of the money off the top needs to be exempted is a very flawed premise to begin with. Again, one of my businesses actually is it's called a contract management company. And we literally provide physicians that staff emergency departments at different facilities across the country. Those are the types of funds that are being exempted from the conversation. So if the premise is that 80% of the money is necessary to practice medicine, well, that practice is actually being done by businesses as well. And there are ways to include diversity businesses into those conversations. So at some level, I would love to be engaged on statewide conversations about the premise that so much of the money needs to be opted out on the front end. And there's a bookend conversation to be had regarding the second assumption, which is that the 20% goal, which I believe came to a total of about $875 million or so, actually only results in about $130 million being realized. And that is a salvo at the BEP, Business Enterprise Program process itself, which, you know, the biggest criticism that perhaps can be thrown at it, other than its relative lack of success, is the process by which Black and Brown and other minority businesses are meant to participate in a system that is institutionalized for subcontractordom, instead of anything that allows any significant number of diversity businesses to ever grow into statuses in which they can become primes. I think it's fair to say that you probably, over the history of this program, would only be able to count on one hand the number of BEP certified businesses, and especially in healthcare, there may be one in the entire history of the program that has ever become a prime contractor and has graduated from the BEP program. So in a conversation with a Chamber of Commerce, where the goal is participation, diversity, equity, inclusion, all different considerations, we really have to continue these conversations with an eye toward how do we get diversity communities involved in participating in the process, because this isn't just an economic conversation, but a conversation that leads toward the production of better healthcare outcomes for all citizens of the state, especially those beset with healthcare disparities and health inequities. With that in mind, I actually would like to transition to our next panelist, Dr. Neva Lubin-Johnson, who is our Chief Health Officer, and as I mentioned, very significantly served as president of the National Medical Association, who brings a global perspective to this conversation, and we'll follow up on the last point about exactly what the interface is between clinical, public health, economic, and business opportunities in healthcare. So welcome, Dr. Lubin Johnson.